All right, well, it's 7:30, so we'll get rolling here. So good morning, everybody. Happy Friday. Welcome to this week's AMSSM Sports Ultrasound case series talk here. So today we've got Terese Whipple. She's our fellow here at the University of Iowa. She's emergency medicine trained. She trained at the other Big Ten institution in Chicago, Northwestern, and like I said, is our fellow here currently. Today she's going to talk about a case of a pec major kind of muscle myotendinous injury. And then just quickly before Terese gets rolling, as always, we are off next week, and the following week, 5/28. Christina Giacomazzi out at UW in Washington is going to be given a case on volar hand pulley injuries. And with that, I will pass it over to Terese and let her get rolling.
All right. Thank you very much, Dr. Cruz. Can you see this okay?
Yep, that looks great.
All right, perfect. Like Ryan said, my name is Terese. I am the current, one of the current fellows at the University of Iowa. And I'm going to be talking through a case of shoulder pain with a little different pathology than the case that Dr. Hall had presented earlier on in this case series. So I have no disclosures. And before I get started, just want to say a very, very big thank you to Drs. Cruz and Hall for all their very patient teaching this year. I haven't always been the quickest study, and they've always been willing to put in the extra time and the extra discussions and scanning to make sure that we're really staying on track with things and mastering these concepts. So big thank you for all your help this year. Learning objectives for this case are the same as they have been for every other case in this series. We're going to try to understand my protocol for sonographic evaluation of shoulder pain and then apply it to a specific case. And then as we go, I'm going to talk through the ultrasound report just so that the images are fresh in our minds when we're describing things. So without further ado, the case today is a 23-year-old minor league baseball player. He's an outfielder. He was left-handed, who came into clinic, was self-referred for some left anterior shoulder and kind of chest wall pain. After an acute injury a couple days ago, he was bench pressing when he felt a pop in his left anterior shoulder and then had sudden weakness. He wasn't actually able to lift the bar back onto the rack and had to have the spotter lifted up for him. He said he never really had any overt pain, but that area kind of felt a little stiff later that night. And then the next morning he woke up and noticed some bruising on his inner bicep the next day. He was a little nervous about what had happened and been kind of trying to test his strength, and it all seemed to be fairly intact. He hadn't found any overt weakness, and he didn't have any radiation of pain or any other associated symptoms. Pertinent positives for exam. On inspection, he did have some ecchymosis of his left medial bicep, but there wasn't really any obvious deformity of his bicep, no loss of pec muscle contour at all, and then no obvious swelling. He did not have any tenderness in the area of the bicipital groove, but did have some mild tenderness, just proximal, just medial to that area over the left distal pectoral muscle. He did have full strength and range of motion at the shoulder and at the elbow with flexion, extension, supination, pronation. And then special testing in the shoulder was all pretty darn unremarkable. We obtained plain films at the beginning of the appointment that were all within normal limits, no bony abnormalities, preserved joint spaces. The AC joint doesn't project very well here, but it was normal. So nothing terribly revealing on his x-rays. So we move on to the scanning portion. My protocol is the same as what's been discussed in this lecture series previously. We, based on his history, are a little bit concerned about maybe a pec muscle or tendon injury, maybe proximal biceps, but more likely pec muscle tendon. But we're going to be thorough and complete a full evaluation of the shoulder with our exam today. However, because of the suspicion that we have about his pec major muscle, we're going to include that in the anterior shoulder evaluation when we are going through and looking and scanning. Before we get started, a couple considerations. I usually use a 14 megahertz high frequency linear array for shoulder. You can use the 18. And then patient positioning is something that's important to consider. Ideally, you're going to start the patient supine with palm in the air, forearm supinated, and then roll them into a lateral decubitus position to look at the posterior shoulder, and then into the modified CRAS where you have them, as is shown here, have them with their hand on their hip and gravity pulling their elbow more medial. However, some people don't really tolerate laying on their side because of shoulder pain, greater trunk pain, whatever. So it's important to kind of talk to them about that before and make sure they're going to be able to actually get into these positions and adapt and have them sit up for the exam if needed. These pictures are going to be at the top right-hand corner of every slide just to help with transducer orientation and making sure everybody knows where we're at. So we start scanning. For me, as for most people, home base for the scan anteriorly is the biceps tendon and short axis with the transducer and an anatomic transversal plane. The patient, like I said, at the beginning of the exam is supine with palm up and their forearm supinated, so you can really bring that biceps more anterior and into view. For bigger people, sometimes you have to toe in a little bit because supination can be a little bit harder. But following the biceps tendon and short axis proximally into the rotator interval as it starts to flatten out a little bit and starts to curve intra-articularly, and then more distal, especially in this case, down to the myotendinous junction to evaluate that and look at the biceps muscle in short axis as well. In this case, his tendon and short axis was normal in appearance. There wasn't any evidence of fluid in the tendon sheath, no tears, no tendinosis at all. So then we flip into long axis and evaluate the tendon there. This is showing the tendon as it starts to curve more intra-articularly, more proximally, which again was normal in appearance with no thickening, no tendinosis, no tendon sheath effusion at all. If you do see some pathology in this area, you can go ahead and throw Doppler on looking for hyperemia or perform some sonopalpation to see if this is actually their pain generator. But like I said, in this case, very normal in appearance. And then move down to the myotendinous junction. I included this slide specifically to kind of show the relationship to the pec major tendon, which we're going to talk about here in a couple of minutes. But as you move down and start to see the biceps start to form the myotendinous junction, you should also see the pec major tendon start to come into view over top. So that's just an important relationship to keep in mind. So we finished our biceps tendon and muscle evaluation, and we want to convey our findings in our report. And in this case, we're going to say the biceps tendon and muscle are intact with no evidence of tendinosis or tear and no sheath effusion. The next structure I evaluate is the subscapularis anteriorly. I have the patient flex their elbow, which you can kind of see in this picture, to 90 degrees and then externally rotate to bring that lesser tuberosity and the footprint of the subscap more anterior, bring it into better view. And then scanning superiorly and inferiorly to make sure that you've actually evaluated the entire extent of the tendon. In this case, he had a very normal appearing tendon with no evidence of any pathology. And then went ahead and did some dynamic imaging, looking for subcoracoid impingement, which can be seen here. And he didn't have any evidence of bursal fluid. You can see that the muscle is gliding very nicely right under the coracoid, so he didn't have any evidence of impingement at all. So for our report, oops, it's activating the wrong thing, sorry. Oh, yeah, sorry. And then we're gonna move into short axis to evaluate the subscapularis. It is important to note that this tendon in particular can have these little hypoechoic kind of areas in it, and that's because the tendon itself is made up of several slips with some interdigitating muscle in between. So this is a normal appearing tendon with no evidence of tendinosis or tearing. So for our report, we're going to say that the subscapularis is intact with no tendinosis or tear, no fluid in the subcoracoid bursa, and no sonographic evidence of impingement with dynamic imaging. And then we move on to the pec major, and we haven't really talked about this yet in the lecture series, so I'm just going to spend a couple of minutes on anatomy before we get started, because this is a little bit of a tricky area. So the pec muscle itself, the pec major muscle itself, is made up of two heads. The clavicular head comes off of the medial 2/3 of the clavicle, and then the sternal head is going to come off of the sternum, costal cartilage, ribs, and a little bit of the abdominal fascia. These two muscles are going to come together and extend towards the humerus, and about 10 to 15 millimeters medial to the humerus. These tendons are going to fuse and rotate 180 degrees. They're going to run across the top of the biceps tendon and the bicipital groove, and then attach just lateral to that on the humerus. It's important to keep in mind that this is it's a very broad tendon that can be like 4 to 6 centimeters in sagittal length. So when you're evaluating the tendon, keep in mind that it is very broad, and it's important to scan superiorly and inferiorly and make sure that you've gotten a good look at the entire extent. And then this is, again, kind of a hard area, at least for me, to conceptualize in 3D. And so scanning it can be particularly difficult. So I put a sample image down here of what's normal. Clavicular head is up top here in the top right-hand corner. Sternal head is deep to the pec major tendon that you can see the hyperechoic line running through the middle of the screen. As you scan more medially and more inferiorly, you're going to lose that clavicular head, and the sternal head is going to take up most of your image. And then you can see the long head of the biceps musculotendinous junction kind of wedged in here in between the humerus and the pec major tendon as it starts to form right around the same area. So for our patient, from the subscapularis, you're going to move more distal. Next structure that you should see starting to form right as that bicep starts to turn into the musculotendinous junction should be this pec major tendon. Humerus is here, this is lateral. Clavicular head is up here, and sternal head we don't get a great image of, but it's down here just deep to the tendon. And this tendon itself looked to be intact, was attached to the humerus very, very solidly, and there was no evidence of tearing within the tendon itself. Did some dynamic imaging internally and externally rotating just to make sure this tendon moved very nicely with the humerus, so it appeared to be fairly normal. And then scanning, like I said, this is a very broad tendon, so making sure you're getting through the entire extent from a cephalad caudal direction to make sure you're not missing any tears down distal. And then evaluating the tendon in short axis. So this picture again emphasizes how broad this tendon is. It's falling off the screen. It's coming out of view on both sides of the screen. But in short axis, again, tendon with normal appearance, no evidence of tearing, no hypoexogenicity or tendinosis. So then we moved on to evaluate the muscles. We moved in long axis because, like I said, this is a tough area to keep your bearings. So making sure you know where the clavicular and the sternal heads are and moving distally from there. Or more proximally, excuse me, moving proximally from there. So we did find an area of injury in the sternal head, just proximal to the MTJ. Here you can see an area of muscle tearing here with hematoma, as well as some adjacent muscular edema and loss of muscular structure. The hyperechoic edema can be seen in the muscle here. Scanning more superiorly up into the pec and more inferiorly down into the pec, there was evidence of retained normal fibers in the more superficial portion or the anterior portion. So the fibers anteriorly were intact in most of the muscle. In this particular area, there was tearing both deep and superficial. We did perform dynamic imaging that I unfortunately could not pull off of Epic and into this presentation, but there was retained movement in with dynamic imaging. There was retained contraction. It was a little bit dyskinetic in this area as expected, but there was retained contraction with dynamic imaging. So then we evaluated this area in short axis. Sorry about that. We evaluated this area in short axis, again, seeing hematoma, muscle tearing, and hyperechoic muscle edema throughout the area of injury. And then we put Doppler on the area, and there was evidence of hyperemia throughout this zone of injury, indicating ongoing inflammation. We then evaluated the entirety of the clavicular head as well, and that was very normal in appearance. So we've completed our pec with a lot to say. So the pectoralis major tendon was intact, without tendinosis or tear. And there was that focal region of intramuscular fiber disruption involving the deep or the posterior, depending on how you want to describe it, portion of the sternal head just proximal to the myotendinous junction, which measured about 1.2 by 1.5 by 1.8 centimeters. There was focal anechoic compressible hematoma at the site of injury. There was hyperechogenicity in the surrounding muscle, which represented reactive edema. And then the remainder of the muscle, including the clavicular head, was normal in appearance, and dynamic imaging demonstrated maintained contraction across the zone of injury. So we found what is likely our injury, but we're not done because this is a complete scan. So the last structure to evaluate while we have this patient supine is the AC joint. In this case, it was normal in appearance with normal bony margins, no effusion. If you do have some pathology here, you can perform sonopalpation just to see, again, if it reproduces their pain. But here it was pretty normal. And you can put Doppler on this area as well. There wasn't any evidence of hyperemia. So for the AC joint, it was normal with no degenerative changes, effusion, or synovitis. And then it's time to roll the patient into the lateral decubitus position to get a look at the posterior structures. The first thing that I look at is the infraspinatus muscle in short axis. And then this image cephalad is on the left. You can see the scapular spine, the scapula here, and then infraspinatus muscle with tendons starting to form here. Teres Minor is on the bottom right of the screen down here. We're looking here for any evidence of atrophy, making sure we have normal muscle bulk and size, and there's no evidence of hyperechoic fatty infiltration at all in this pretty healthy baseball player. And then we follow this out laterally, and I, at this point, like to look at infraspinatus and short axis. You can see tendon here with Teres Minor tendon attached just inferiorly. And then I rotate into long axis to evaluate the tendon. And you can see muscle down here. Tendon is very normal in appearance with nice fibers, no evidence of any thickening or hypoechogenicity, no tears, and no tendinosis. From there, I guess, sorry, first things first, we've finished our evaluation of the infraspinatus muscle and tendon. And it's intact with no tendinosis or tear, normal muscle appearance without any atrophy or fatty infiltration. And then from there, I like to look at the Teres Minor tendon. I usually just move in long axis more inferiorly to try and bring it into view. It can be really tricky because this is a very small tendon, and getting your fibers oriented underneath the transducer is sometimes difficult. But in this case, again, the tendon was normal in appearance, and the muscle which we've previously evaluated had no pathology either. So we say that the Teres Minor tendon and muscle were intact with no tendinosis or tear, normal appearance of the muscle without any fatty atrophy or infiltration. So then at this point, I like to look at the glenohumeral joint because we're right in that area. Looking for any posterior glenohumeral joint, sorry. Looking for any evidence of synovitis, any evidence of effusion. Humerus is here, glenoid here, and then labrum is a little hyperechoic triangle here. In this case, there was no effusion, no synovitis, was pretty normal in appearance. And then next structure I like to look at is the Spinoglenoid Notch. I do both the spinoglenoid and suprascapular at the same time. So from the posterior GHJ, I come a little more medial, just past the glenoid, and then rotate the medial portion of the transducer to get the spinoglenoid notch into better view. Looking for any evidence of paralibral cyst or mass. There's always usually vasculature that lives in this area, which can fool you. So you can either put Doppler on and confirm that the hypoechoic circular thing that you're looking at is actually vasculature. You can also perform dynamic imaging and see if this If the vasculature engorges, it is in fact a vessel. If it stays the same size, then you're more concerned that this is actually a cyst. So the vasculature will actually get larger with larger and smaller with dynamic imaging. And then I glide superior, oh, sorry. Yep, I forgot to make this part actually animated, I apologize. So then I glide superiorly over the scapular spine to find the suprascapular notch. Again, evaluating for any evidence of cyst, taking a look, throwing Doppler on, and making sure that what I'm looking at is actually vasculature. In this case, he had no evidence of any abnormality, no cyst. So we say for the spinoglenoid and suprascapular notches, they're normal in appearance with no cyst or neurovascular abnormality noted. And then I like to evaluate the supraspinatus muscle in short axis. So again, looking here for any evidence of atrophy, fatty atrophy, making sure that we have normal muscle bulk, and then following that out distally to the tendon in short axis. When I'm evaluating this, I put the patient in a modified CRAS position with their hand on their hip, like I talked about earlier, and the elbow falling with gravity a little bit more medially. So following the muscle out to the supraspinatus tendon in short axis, ideally finding it at the rotator interval so that you have the biceps tendon for orientation and making sure that you're actually evaluating the full extent from anterior to posterior of the tendon. Make sure you're getting that anterior margin there. And hopefully seeing this nice tire on a wheel appearance, as we call it. In this case, he had no evidence of any tendinosis or tearing in short axis. And then rotating into long axis on the superior facet of the greater tuberosity and seeing that footprint of the supraspinatus tendon in long axis. Again, with no tendinosis or tearing, very normal appearing tendon. And then looking at the subacromial bursa, making sure that there's no fluid. In this case, he had no fluid. And finally, performing dynamic imaging, looking for evidence of subacromial impingement, any bunching of this bursa or tendon. And he had nice uninhibited gliding of the tendon underneath all right. So we finished our subacromial bursa, or subacromial tendon evaluation, and it was intact with no evidence of tendinosis or tear. A normal muscle appearance with any atrophy or fatty infiltration, and no sonographic evidence of impingement with dynamic imaging. So finally, putting it all together in our report, I'm not going to read through this because we've already been through most of this so far. But again, putting the diagnosis of why he was referred, he was self-referred in this case, making note of what transducer and what ultrasound machine you used if you have multiple, what type of study this was, and then any comparison images. In this case, we only had plain films to look at. He did get subsequent follow-up ultrasounds. So if this was a second or third ultrasound, noting that we were comparing these images to previous ultrasounds that have been done. And then for the findings, just including everything that I've already run through in the presentation, I'm not going to talk through that again, but in summary, he did have a focal intramuscular tear of the pec major muscle sternal head as described above, with no evidence of tendon injury. So that is all I've got. Thank you guys. Does anybody have any comments or questions?
Hey, great. This is Ryan. Great job, Terese. That was really well done, and I think laid out in a very organized manner, which is really important. I just have I think 2 or 3 comments to make quickly, and then I'll open it up for anybody else to make some comments. So, you know, the protocol here is important, and all of us have different protocols in terms of, you know, the way we go through them, how we visualize them. You know, there's some nuances here. And I don't think there's a wrong way with any of the protocols, as long as you have your protocol and you go through it the same way every time. I think protocols are helpful to allow us to make sure we have, you know, a complete, not a limited examination for reasons we've mentioned previously, and also to make sure we don't miss structures. On the flip side, though, the ultrasound evaluation of these patients, we're not a robot and we're human, right? So humans are able to think, and we're clinicians, so we should be able to alter our protocol to fit our clinical picture. And so, the pec major tendon, the only time I'll look at it in my typical shoulder protocol is as I'm going down to biceps, myotendinous junction. That's not part of my standard protocol, but in this patient, there is a clinical concern for a pec muscle or tendon injury. And so altering and adding to your protocol, I think, is important. So I guess my point there, is have the protocol, know your protocol, but be able to alter protocol based on clinical suspicion. Is really important. And kind of the converse or inverse of that is stick to the protocol, because with this, with this athlete, very clearly this is a muscle or a pec injury, for all the world. It's very clear. And sometimes we get excited and, hey, this is a pec injury, and we run to that structure and, ooh, look at the tear and look at whatever's going on, and you forget about the rest of the protocol. And sometimes you can get burned, if you don't do a full evaluation. So I just think it's important to use the protocol and also have clinical judgment there. The other point to make quickly, so the pec region, the pec major muscle and tendon is a challenging area to scan for a couple reasons. Your clavicular head and sternal head are coming in at a bit of different angles as they form that tendon, versus most muscles. All those muscle fiber are oriented in the same direction. So really knowing your anatomy here can be helpful to not get lost as to where you're at. And additionally, as you're coming down to the tendon, this tendon does this thing where it flips over on itself, so that clavicular head kind of wraps, anteriorly and ends up inferior to the sternal head, and the inverse is true for the sternal portion of the tendon. And so it's a bit of an area of somewhat challenging anatomy. So knowing the anatomy here is helpful to really, differentiate, is this a full tendon tear? Is this a primary clavicular head versus sternal head, so on and so forth. So those are just the points I wanted to make. I don't know if anybody else has any comments. Doug, I think you're out there.
Yeah, Terese, again, a nice, concise. I don't have much to add to that. It was just very well done. I would just say, one of the, as Brian mentioned, one of the original intents was to talk about protocols, talk about reports. So if I get a referral for an obvious pec major injury, I do what I call an anterior shoulder protocol. And if I'm not sure, I do exactly the protocol that was presented. But if it's a pretty obvious pec major, then I do what's called, again, an anterior shoulder. So I do the subscap tendon. I'll do the long head of the biceps tendon. I will look at the long and short head of the biceps as it comes down, because that's, again, that affects the insertion of the pec major tendon onto the humerus. And then I'll also take a look at the coracobrachialis as well. So that's just, if it's an obvious pec referral, that's my protocol. If it isn't obvious and it's shoulder pain, then I do, again, exactly what's presented. So I don't know if anybody else has any comments on their protocol for this. But again, nice presentation. And again, just reiterating, these are hard. Pec majors are hard, and they're not that common. So, we might go 2-3 months without an injury, or sometimes even longer. And then all of a sudden we get a couple of these. So always have to refresh our anatomy.
Thanks, Doug.
Hey, Doug, can I ask you a question about your anterior scan? So, we've kind of been harping on, this complete versus limited examination. And so if you're just doing an anterior scan, looking at the structures that you mentioned, again, depending on what resource we look at, some definitions of a complete examination have to include, joint bony structures, neurovascular structures, so on and so forth. So are you billing for a complete exam if you're doing an isolated anterior shoulder?
Yeah, good question. So when I do the subscap, if you do a dynamic study, technically you're getting a joint. If I'm looking at the coracobrachialis, I'm also looking at the musculocutaneous nerve. I also include just a pec minor in my protocol for the pec major. And if you're looking at the pec minor, then again, you're going to see neurovascular structures. So that fulfills that criteria. So for me, as long as I'm getting muscle, I don't necessarily technically get ligament, but if I'm getting muscle, I'm getting tendon, I'm getting joint, and I'm getting nerve or vessels, neurovascular structures, then for me, that meets the criteria of a complete exam.
Perfect. Thank you. All right, we are right at 8. Anybody else have any last minute questions, concerns, thoughts, comments, dreams, desires? Perfect. All right, so one more time, great job, Terese. That was really well done. Those are really challenging scans. Again, off next week, 5/28, we're back. Our Washington folks are going to talk about volar hand pulley injuries. And otherwise, everybody can get back to more exciting things. Have a happy Friday, and we'll see you all in a couple weeks.